Chairman Doggett, Ranking Member Nunes, and members of the subcommittee, thank you for this opportunity to testify. I'm James Gelfand, Senior Vice President for Health Policy at the ERISA Industry Committee, a trade association representing large employer plan sponsors. Our member companies offer comprehensive health benefits, and as self-insured plans pay around 85% of healthcare costs for our beneficiaries. About 181 million Americans get insurance through their job, and surprise billing fundamentally frustrates the goals of providing quality, affordable, employer-sponsored coverage. Often our employees do everything right. They look up in-network providers, they call ahead, they ask questions, but still they receive enormous unexpected bills. Many beneficiaries are afraid to go to the hospital, even with a platinum plan. They're skipping care, they're worried while they're at work, and this has become a crisis. Now, the vast majority of providers never generate surprise bills. It's a small subset of the health system that the patient cannot choose, specifically in 3 scenarios. Number 1 is when a patient receives care at an in-network facility but is treated by an out-of-network provider. Number 2, a patient requires emergency care, but the providers, the facility, or the transportation are out of network. Number 3 is when a patient is transferred or handed off without sufficient information or alternatives. Employers believe that Congress can and should solve this problem, and that the best solutions will be simple, straightforward, and common sense. Chairman Doggett, thank you for your leadership on this issue. You introduced the End Surprise Billing Act in 2015, which most importantly would hold the patients harmless. We believe that ending surprise billing starts with the concepts that you pioneered. ERIC proposes 3 core policy changes to decisively end the surprise billing crisis. First, an in-network matching rate guarantee. It's simple. If a patient goes to an in-network facility, every provider they see should be required to accept in-network rates. Second, an emergency, last resort, benchmark backstop. When plans and providers cannot agree on rates for emergency care, set a benchmark. The best solution would be a percentage of Medicare or the average privately contracted rate. Third, require informed consent. When a transfer or handoff takes place, inform the patient if the care will be out of network and offer an alternative when possible. These 3 policies would wipe out the vast majority of surprise medical bills. There is more that Congress should do, including crack down on abusive behavior by outsourced medical staffing firms and banning certain kickback agreements. But this would already be an incredibly effective start. And the Ways and Means Committee can make this happen by making these simple rules a condition to participate in Medicare. No new taxes or spending needed, no complicated insurance rules, just an opt-in, and let providers vote with their feet. Now, we know that Congress is under immense pressure from certain providers, hospitals, and Wall Street investors to maintain the status quo. They're sending Congress on a series of snipe hunts designed to derail legislation. For instance, the first snipe hunt is a call for mandatory binding arbitration. Playing on the fear that making changes to the healthcare system will cause changes, some have urged Congress not to specify how to solve the problem and instead to punt to arbitrators. Arbitration is a dodge to deflect tough decisions away from Washington that will raise costs for patients. When employers determine the premium costs, we will have to build in costs to pay arbitrators, pay facilities, pay for gamed arbitration thresholds, and pay exorbitant list prices demanded by providers. If providers can make more money by arbitration rather than by participating in networks, patients will pay a very heavy toll. Next, transparency alone will not solve this problem. We are dealing with a market failure and de facto monopolies. Informing a patient that they will be seeing the only anesthesiologist on duty who happens to only accept cash doesn't actually help the patient. Transparency is important, but it's not enough. Some have warned Congress that if you legislate on surprise billing, you risk creating winners and losers. To this we respond, obviously. The current system is not perfectly balanced, and the current losers are patients. The idea that the deep inequities in the current system can be solved without changing anything is another snipe hunt. Others say that the free market will solve the problem. It won't, it hasn't, and surprise billing is getting worse and not better. They say that if Congress creates a benchmark, it's big government interfering in a free market. We disagree. Lastly, some have advocated deferring to the states, but many states have either not acted, have enacted only half measures, or have actually made things worse. Even if every state enacts a comprehensive solution, this still won't help the 100 million Americans in self-insured plans. In conclusion, thank you for this opportunity to share our views. The ERISA Industry Committee is eager to work with Congress towards a bipartisan, comprehensive solution that protects access to care and ends the surprise billing crisis without driving up health insurance costs. I'm happy to answer any questions.
Mr. Gelfand, why won't the New York arbitration system work well?
Unfortunately, our belief is that arbitration raises costs and it doesn't eliminate surprise medical bills. What it does is rearrange the deck chairs on the Titanic and send those surprise bills to somebody else to pay. Inevitably, in New York, what happens is when a provider does win the arbitration, the amount that the insurer must pay is the billed charge, which, as you saw in the video, no reasonable company would ever agree to pay. My companies right now have the option of participating in certain state programs that would have arbitration, and so far we have not heard from any company that has chosen to do that.
The importance of informed consent, too, is one of the possible options. Gets into the world of price transparency. But listen, I mean, if you're seriously injured or seriously sick and you got to get to the hospital right away, I don't care how much informed consent there is or how much price transparency you have. For the patient's perspective, that's not going to work very well, is it?
It's also not reasonable to expect the patient to ask those questions as they're on a gurney or in an ambulance. One of the things that I don't think we've mentioned yet is that almost all of the providers that are generating these balance bills are providers that you don't have a choice of whether or not to see. We use the acronym PAIR, which stands for Pathology, Emergency, Anesthesiology, and Radiology, and the sidecar is maybe ambulance and air ambulance, but it's not a huge problem that many different kinds of providers are causing. It's really those providers who you're stuck. You're going to see this person or you're going to see nobody. I just say that the situation you described, in which there is very little choice of provider, is a recipe for price gouging. And in fact, the patients who are going to be seen by a provider in that environment are probably in need of the most protection from these surprise bills, because there may be no incentive to participate in a network if you're the only game in town. We would agree that taking the patient out of the middle is the very first step that absolutely has to be done, as Oregon did. We would just caution that eventually someone does have to pay the bill. And if that bill has to be paid by an insurance company or by an employer sponsoring a plan, then what happens is, if you don't address the underlying issue that is causing the generation of those bills, that the prices will just be spread throughout the premiums. And instead of one person receiving a surprise bill, every enrollee is going to be paying for that surprise bill.
What would happen if we pass a federal law to address surprise billing that differs from state laws that are currently operating? Do you believe that federal law should supersede the state laws? And if not, what would the impacts be to providers, patients, and plans in states with different surprise billing laws? Yeah.
If I could just speak to it from perspective of national employers that run plans for employees in every single state, it would be important for us that there is one standard that applies to all of our beneficiaries, no matter where they live, work, or receive medical care. That being said, those are only for those self-insured large plans. For a fully insured plan that is already regulated on the state level, it would make perfect sense for state law to govern unless there is no state law.
Where have you seen the most surprising billings for your members, hospitals, ambulance, and where the patients are experiencing the highest balancing bills?
So those balance bills are very heavily focused on providers that are ancillary, that are at the hospital, that once you go to the hospital, whether it's in network or not, you don't have a choice. You don't get to choose your anesthesiologist. You don't get to choose who operates on you in the emergency room, and especially when you're talking about transportation, air ambulance.
Let's say the patient at the end of the day is held harmless, so it all gets taken care of. But in the system, there seems to me to be a lot of windfalls and a lot of shortfalls along the way. Shortfall to the patient, a shortfall to the hospital, potentially the insurance company. Is there a windfall? Is someone in this system making a windfall in the dilemma we're talking about?
If I could just interject, for one thing, we will do a disservice to patients if we protect them from hospital bills, but they're already bankrupt just from the trip to get there.
Fair enough.
And that's why ambulance and air ambulance has to be included. I don't think that we've mentioned yet today that many of the hospitals are not doing what Zuckerberg Hospital was doing. The hospital will be in network, but they will have outsourced their emergency room to a Wall Street-owned private company, and that company won't take insurance. And those guys are definitely making enough profits that Wall Street is suggesting that people should invest in those companies because of these relationships they have with the in-network hospitals and the out-of-network emergency rooms.
How is the California law working, and what are some of the shortfalls? I understand the big shortfall is it doesn't deal with a big chunk, but how is it working in the field?
It's our understanding that California took bold steps to solve this problem, and we have not seen borne out some of the warnings that were given about various solutions. There has not been a mass migration of physicians out of the state of California. People are not losing access to care. Rather, surprise bills are being stopped.